operability is mainly influenced by the two factors. One is the surgical judgment based on the surgeon, that is to achieve the negative resection margins, and second is the feasibility of adequate recon for meaningful quality of life. Now the first thing is, in any management part, the first is a diagnostic workup. So NCCN guidelines shows a diagnostic workup where we took the complete history and physical examination part. We do the biopsy, and then the importance of the radiological part, where we do the chest CT and CT or MRI with the with contrast. Then the requirement of PET CT if the disease is going towards the metastatic side or unknown primary. Then examination under anesthesia for endoscopy part, and other evaluation like dental evaluation, nutritional speech swallowing evaluation, and other sub parts. So accordingly, then we do the clinical staging, and then we decide the treatment part. Now here the role of imaging is very important, specifically to see the signs of inoperability and resectability, to see the extent of tumor spread, whether the disease is involving the bone or the soft tissue, and then to plan the surgical part based on this pattern. So this is an article which shows on the imaging uh, regarding the comprehensive view of imaging findings. So basically, when we come to the advanced local disease, the mainstay of our findings in the radiology is the lesion involving ITF and the masticator space. So in this picture, we can clearly see the green arrow part, that is your masticator space, and that yellow part is your signifies your ITF part. Now the ITF part, which is signified by this yellow part, it shows that how the boundaries are well served. Like it is bounded on one side by the posterior surface of the maxilla and the inferior orbital fissure on anteriorly, then mastoid in the tympanic portion of the temporal bone posteriorly, and the greater wing of sphenoid superiorly, and the pterygomaxillary fissure and the lateral wall of nasopharynx medially. And the content is very important, specifically the retroventral buccal fat masticator space and the parapharyngeal space and the vessels like internal maxillary artery. Similarly, this the green part, that is the masticator space, the boundaries are very important to define this suprahyoid deep fascia space, which is bounded by the slips of investing layer of cervical fascia and consisting of the main masseter, lateral pterygoid, and the medial pterygoid and the temporalis muscles, all the muscles of the mastication. So considering the complex anatomy of the oral cavity and the surrounding structures, imaging is important, not only in the staging but also in the metastatic workup. And the important features which must be assessed on CT or MRI is to see whether the disease is involving high or low ITF, whether there is a bone involvement, whether there is a perineural involvement, and whether there is any extranodal extension. So according to these NCCN guidelines, in cases of advanced oral cancer, yes sir, yes sir.
Like as you were discussing about the like in your imaging will help you in deciding and finding out that unresectability criteria. So just can you tell us like what are those unresectable criteria? Or like nowadays we don't use the exact word unresectable, we use it technical your unresectable, because maybe because nothing is unresectable, you can cut everything, but
Sure.
what we are going to achieve, that we have to see. So
Yes sir.
like what are those criteria?
Sir, criteria for unresectability is if the diseases of the tongue is going
Technical unresectability.
Yes sir.
Don't say it as your as a unresectability, just like say it as a technical unresectability. Okay.
Yes sir. So if the disease is going beyond the tongue of, if the lesion of the tongue is going beyond the like follicular or base of tongue.
Criteria. Can you just tell us one by one?
Yes sir. So first criteria is if the disease is of the tongue is involving beyond the base of tongue or vallicula. Secondly, if it is the disease involving going beyond the hyoid bone below, extending beyond the hyoid bone. Then third, if there is a extensively like the any disease of any CA of buccal mucosa or GBS which is going above the suprasigmoid nodes involving the high ITF. Then fourth, if it is involving the base of skull or intracranial extension. Then if the disease is involving the pterygoid structures, if it is going beyond the pterygoid extension, or
one more feature like encasement of internal carotid.
Carotid, yes, sir. Encasement, more than 270-degree encasement of carotid or mediastinal structures and prevertebral fascia.
So the main point with Rizul is that like we can cut or like we can remove each and everything, but what we are going to achieve, what is our end goal? As you were telling and discussing, that we have to also see the quality of life. Now, if the disease is going up to hyoid, so like we can even remove the larynx also. With tongue, we can go for total laryngectomy. But like then after doing that, what we are going to achieve? How much like we are hampering the patient's life, like his quality of life, and then we also have to see like in such cases what will be his DFS. So those things are there. That's why we say it is a 10. Like if the disease is going up the hyoid bone, then such cases are called as technical unresectable.
Yes, sir.
Those cases are not unresectable. For those cases, we use it is technically unresectable.
Yes, sir. Yes.
And the same goes with the base of skull, because as we know that everywhere the minimum margin should be 5 mm or more than that. And like once the disease has crossed, like it has entered into the foramina, it has gone into the sphenopalatine and all. In those cases, we are not very sure that whether like we are doing, even if we are drilling out, like whether we are like we will be getting that margin of 5 mm more than that.
Yes, sir.
Okay, let's go.
Yes, yes. So the management part after the clinical staging and the diagnostic workup, we comes to the treatment part. So if the disease is like the one which is involving the T3 or T4 staging with the N2 N3 nodal involvement, the preferred treatment is always, most of the time it is a surgical surgery only which is the preferred treatment. Yes, sir.
You have not discussed about the imaging. No.
Sir.
What will be your imaging? Like as you are discussing about the advanced cases, so I suppose advanced cases are maybe T3, T4, or like you're discussing like T4A, T4B cases. So what will be your line of investigation? Sir. Have you discussed all those things or not?
Yes, sir. Yes, sir. Yes, sir.
In the further slide, we have discussed those things.
Sure. Yes, sir. Yes, sir. Sir, the line of investigation for the like, if it is the disease is involving T4B, then definitely we need to do the CT chest with the requirement of PET CT.
Only in T4B, not in T4A.
Sir, metastatic workup, sir, for any disease, we have to do the metastatic workup for all of them, whether it is T4A or T4B. We have to do the CT chest. We have to do the CT face, neck plus like NCCT thorax. It's a part of the metastatic workup, sir.
Why even? Suppose we don't do that, so how it is going to change our like treatment?
Sir, to see the extent of involvement and to see whether or not any nodes are involved, sometimes we found it over the even the X-ray also, like some lung nodules are there and some. So it depends. Patient selection is a very important criteria whether to decide we go for the surgery or not, based on the
so
to decide whether we have to go for
much information.
No, sir. No, the any oral cavity SCC, it will fall into the 3 categories, whether it's a low risk, intermediate risk, or high risk. So we define it like if it is a low risk, that is a T1, T2 with the clear resection margins, which is more than 5 mm, with no microscopic muscle invasion or no other lymphocytic invasion, the treatment is surgery alone with expected outcome, which was more than 90% 5-yearly, according to the one study, that is the Shanhui Huang study. If it is an intermediate risk of the disease involving T3, T4 with close margins, with lymphocytic invasion and perineural invasion present, and positive lymph node status, but without any extracapsular extension, the treatment is, after the surgery, we will go with the radiotherapy, and 5-year survival rate was 78%. But if it is a high risk category with the positive margins and extracapsular extension, then the treatment of choice is to go post-operatively both chemo and radiotherapy, with expected 5-year outcome was 80%. So these are the basically the NCCN guidelines to decide the unresectable disease. If there is an involvement of pterygoid muscles associated with involvement of pterygopalatine fossa, erosion of base of skull, sphenoid bone with widening of foramen ovale, encasement of internal carotid, defined radiologically as a tumor surrounding the carotid more than 270, with involvement of mediastinal structures, involvement of prevertebral fascia, the direct extension into the superior nasopharynx or extending into the lateral nasopharyngeal wall. If the disease is externally involving the skin with extension to the neck part and presence of subdermal metastasis. So this is the one study of Patel et al. That shows if the disease of buccal mucosa primary with peritumoral edema going up to or above the level of zygomatic arch without any satellite nodules, or the disease of tongue primary but it is extending up to or below the level of hyoid bone, or if there is extension of tumor into the high ITF, which is defined by the axial plane passing at the level of sigmoid notch. So there is one paper of Trivedi et al. That shows the involvement of masticator space T4B. It doesn't in the paper they have mentioned that every time it's not advisable for all T4B lesions that we always will go for the palliative treatment only. Sometimes even in T4B we can go with the surgical part, but depending upon the involvement of the disease with the limited spread. So in order to downstage further these T4A classification, they have mentioned in an article and given that ITF classification and divided it into 3 parts, whether it is a low ITF, intermediate ITF or high ITF. If the disease is having the low ITF, that means it is the involving medial pterygoid and the masseter muscles or the ascending ramus of mandible. It is the infranotch case where we can plan for a surgery. If it is an intermediate ITF, involvement of these structures plus lateral pterygoid and temporalis plus the lower half of pterygoid plates, still it is the low supranotch and we can still plan for the surgery. It is only the category 3, that is a high ITF involving the pterygomaxillary fissure or beyond or above that, where we usually plan for palliative therapy or NSTD therapy. So this is one data of according to the Indian Council of Medical Research by the DCRUS, where they have defined the disease as locally advanced operable or locally advanced inoperable or a metastatic disease, like stage 3 and 4A, which is locally advanced operable, requiring multimodality treatment of surgery plus adjuvant therapy. Then stage 4B, that is locally advanced inoperable, where we can go with palliative chemoradiotherapy, and then metastatic stage 4C, where the goal is always for a palliation. But to offer the chemotherapy, it depends a lot on the performance status of the patient also. Then there is one article of Calabrese regarding the compartmental tongue surgery to decide the oncological results. The thing was that compartmental tongue surgery was defined as each hemi-tongue bounded by the lingual septum on the midline and further by the stylohyoid ligament and the muscles and the mylohyoid muscles. So So in this part, they have mentioned that by doing the compartmental tongue surgery, the local disease control was 88.4%, which was better than the going with the which was better than the classical surgery part. Same was with the loco-regional disease control, which was much more better, and as well as the overall survival rate. So the outcome was better by doing this, the newer approach, that is the compartmental tongue resection for the tongue surgery. Then there was another trial by the Gopal Krishna Iyer regarding the comparison of surgery and adjuvant radiotherapy versus concurrent CTRT. If the disease is more advanced, non-metastatic head and neck SCC, in this they have mentioned that in all the advanced stage disease of head and neck cancers, specifically in the disease involving the oral cavity and maxillary sinus, the 5-year survival rate was much better if the patient undergo surgery followed by radiotherapy as compared to concurrent CTRT. It has been shown in the diagram. It has been shown in the this graph also, that surgery with adjuvant RT has a better disease specific survival rate and lesser chances of loco-regional recurrence. So what is the conclusion up to right now, that what is the primary goal of surgery with the curative intent is to remove the primary with as much surrounding tissue as necessary to ensure that all the macroscopic disease must be eradicated, with the thought to provide the best chance for the microscopic disease extension removal also, and more is the better approach. So always try to take more than 1 centimeter of healthy tissue beyond the macroscopic margin. Then if the disease is unresectable or inoperable, what are the approaches? Either we go for the definitive therapy or palliative therapy. Definitive therapy can be concurrent CTRT or induction chemotherapy followed by definitive RT, or induction chemotherapy followed by definitive CTRT. Whereas in palliative therapy, we go either with the chemotherapy alone or palliative RT or supportive care, and all these depend upon the patient selection performance scale. For that, we use the Karnofsky performance data scale, and we classify them if they are able to carry out the normal activities or not, or unable to work or live at home, or very varying amount of some assistance required, or if they are unable to carry out their day-to-day regular activities. So the first part is when to go with the concurrent CTRT. There was one trial of Benjamin which mentioned about the meta-analysis of the chemotherapy in head and neck cancers. So basically they have explained when we should start with the optimal timing of chemotherapy. So they compared basically the 3 things, that is the induction part, if we are going with the induction chemotherapy, or with the concomitant chemotherapy, or with the adjuvant chemotherapy, and they find out that both the event-free survival and the overall survival was much better if we go with the concomitant CTRT. As it has been shown in the diagram, they have clearly cut shows that concurrent CTRT has a much better survival rate than induction or adjuvant chemotherapy. Then there is another Bernier trial to show the comparison of post-operative radiation therapy with or without concomitant chemotherapy for locally advanced head and neck cancers. So here we compared the use of concomitant cisplatin and the radiation therapy with radiation therapy alone for stage 3 and 4. And in both the curves, in this Kaplan-Meier curve, they have clearly shown that survival rate was much better if we use the concomitant chemo and radiation therapy better than adjuvant radiotherapy alone. Then if we go for the induction chemotherapy, what are the advantages regarding the use of induction chemotherapy? The advantages of using the induction chemotherapy is it reduces the tumor volume, it increases the locoregional control, it improves the organ function, and treat the subclinical metastatic disease with a favorable initial response, and then to predict further whether to go for the organ preservation surgery or not. So there were various trials which goes first initially to decide the use of chemotherapy, as one trial in the Lisa Lictrias trial that shows that by addition of primary chemotherapy to the standard surgery, we can improve the overall survival rate because it reduces the number of patients who can undergo the surgical part or post-operative radiation therapy. But again, there were some limitations of this study. So it was not so much highlighted.
So Rizul, what was the outcome or the conclusion of this Lisi-Lisi trial?
Sir, main outcome of this trial was that we can we can go with the initial chemotherapy part, we can go with the induction chemotherapy part, and then we can plan for the surgery because it will reduces the burden, surgical burden, tumor burden.
Are you sure? This trial was for your, as you are already discussing and saying this is for resectable tumor. So these were mainly for T3, T4A tumors. Okay, so by this trial it has been shown that there was no overall survival benefit.
Sir.
Okay, by giving the induction chemotherapy in the resectable cancers, in resectable oral cancers. And as you were talking about the McKenzie or the analysis, so what was the flaw of that analysis?
सर आपके ना
कोई अपन जस्ट वैसे उसको छाप दिया लिख दिया है बस डायरेक्ट
सर सर एक बार रिपीट करेंगे सर, एक्चुअली वॉइस ब्रेक हो रही है सर थोड़ी आपकी सर.
अच्छा हाँ मैं ये बोल रहा हूँ कि लाइक आई एम टेलिंग एक तो लाइक फॉर दिस स्टडी लिसिट्रा
yes sir,
that final conclusion was that there is no role of induction for the neoadjuvant chemotherapy for the resectable oral cancers.
Sir.
Because it doesn't give you any benefit of your total survival.
Yes, sir.
Sorry. And secondly, as we were discussing about the McKenzie, so the McKenzie, the fallacy or the flaw is that it is not discussing whole and soul about the oral cavity cancers. I think your topic is regarding locally advanced
oral cavity.
So
oral cavity. Yes.
So you have to be more focusing on this topic, no? Because CTRT and all those comes with oropharynx, larynx, and other things. So as you are talking, CTRT is better. So I think there was a total 91 trials, and there is a meta-analysis of those trials. And in that, they have not separately extrapolated or discussed about the result for the oral cavity cancers. So it is as a combined result they are showing, whether it be oral cavity, oropharynx, laryngopharynx.
So,
okay, that has to be highlighted. And not with Lisi, just go again and see.
Okay, sir. I will read once this trial, sir, Lisi trial, sir, once. Yes. Further, there was one study of Patel et al. Study that shows the role of NACT followed by the surgery in the very locally advanced unresectable oral cavity cancers. It was a retrospective study where they have shown the comparison of whether to use the 2-drug regimen or the 3-drug regimen. So the 2-drug regimen, which consists of either the combination of docetaxel with cisplatin or with carboplatin, or the combination of paclitaxel with carboplatin, and they have shown that the 2-drug regimen was having the better influence than the 3-drug regimen due to some logistics and some comorbidities. These logistic issues they have seen were the finances or unwillingness for prolonged admissions or inability to follow up in the OPD department till the next cycle. So this was a graph that shows the overall survival rate if we go with the neoadjuvant chemotherapy followed by the surgery, and they have clear cut shows that there it has a better overall survival and outcome, or the disease free survival outcome. Then going with the yes sir.
For how many years? 1 year, 2 year disease free survival?
No sir, it was the disease like 5-year survival rate there. The data was like for 4 years sir, between 2008 to 12, where they have studied this data, and they have shown that overall the survival rate, which was a 5-year survival rate sir, that much better in using the neoadjuvant chemo followed by the surgery compared to the surgery alone. So with this they came to the conclusion that all the patients of R0 resection or on the pathological examination, the median decrement in size of the tumor was 50%. With the surgical resection, it has a positive impact both on local and survival. And the overall survival rate of the patients with surgical treatment and adjuvant therapy was 19.6 months, while it was lower for the patients who undergo directly radically CTRT. The results basically shows overall that NACT can improve our survival rate. Then there was another study of one Digvijay Patil, that on the locally advanced oral cancer, specifically on the buccal mucosa, and it again shows the same conclusion that NACT induces the high response rate and may facilitate the definitive surgery in the borderline case, or where the margins identification is difficult due to the wet edematous borders of the disease. So again, it shows the same thing, that NACT may improve our overall survival rate. Then what if the patient came with the recurrent oral cancers? There are some salvage treatments that we can go with. But the most important thing is first to decide the patient selection, which is a very important key factor to decide the outcome. As well as outcome depends upon the other parts like the final histopath report and some patient related factors also. Like final histopath report, regarding if there is an extracapsular spread or positive tumor margins, if there is any regional recurrence, or if there is a multimodality treatment, all for the worst outcomes. Therefore, thoughtful planning is very important thing to decide the surgery, particularly the reconstruction, or the decision that to proceed with a non-surgical approach instead of going with the surgery. These were some of the trials that are still undergo, showing the combination of immunotherapy and the surgically salvage therapy for the recurrent head and neck cancers, specifically to the oral cavity part. And they shows that indications of adding the immunotherapy, which can improve the survival and preserve the organ function. Another trial was the Keynote 048 trial of using the pembrolizumab with or without chemotherapy for the recurrent or metastatic head and neck cancers. In this, the main eligibility was of the disease involving the oral cavity, oropharynx, or further hypopharynx and the larynx part. And here we randomized the data, and we basically divide it into the 3 parts. First part is where we give only the pembrolizumab therapy. Secondly, if we give pembrolizumab with chemotherapy. And third, if we give cetuximab with chemotherapy without the use of pembrolizumab. So the most important thing to decide this treatment, this surgical, this part was based on the PDL1, that is the programmed cell death L1 ligand combined positive score to decide the further the outcome. So in this, that combined positive score of whether it is more than 1 or not, we find out that pembrolizumab plus platinum and 5-fluorouracil is an appropriate first line of treatment for the recurrent and metastatic head and neck cancers, whereas pembrolizumab monotherapy is an appropriate first-line treatment only for PD-L1 positive recurrence or metastatic head and neck cancers. Then there come the role of metronomic therapy. What is metronomic? Metronomic means when the low doses are given on the continuous regular schedule. So it works on the basic principle of anti-angiogenesis, immunoregulatory and cytotoxic action to decide the further favorable oncological outcome. So one study of Patel et al. That shows the use of oral metronomic therapy for the recurrent metastatic or inoperable head and neck cancers. In this therapy, they uses the methotrexate along with the celecoxib versus the use of cisplatin, and to find out the primary outcome of overall survival and other secondary outcomes like progression-free survival, toxicity, and the quality of life. So the results clearly cut shows that metronomic therapy at 6-month overall survival rate has a better survival rate, as well as for progression-free survival rate, which was also much better if we use the oral metronomic therapy, chemotherapy, versus the use of only chemotherapy alone. Then the next is what is the role of surgeon? Because we have already discussed about the definitive and palliative therapy role, but what is the role of surgeon if the disease is unresectable? So if there is an airway compromise, because if the disease is like compressing any oral cavity, specifically the tongue cancers, which are compressing the base of tongue tumors or extending beyond that, or there is some secondary to some bleeding, hemorrhage, some infection, or post chemo radiation edema, or aspiration or metastatic disease which is compressing the airway, the main management part is first to stabilize, then the use of steroids and nebulization, requirement of intubation if feasible, or to go with the tracheostomy part, whether emergency or elective. Because airway secured is the first thing we need to do. Then if the patient is having the complaint of dysphagia, which is like in most of the patients they already have this complaint, rehab is very important thing. So we should always take the opinion of speech swelling pathologist. Oral hygiene is important maintenance. Then to manage other side effects like xerostomia, mucositis edema, management of dyselectrolemia, and the use of Ryle's tube insertion if required for the enteral feeding. Then the vascular complications, like if there is a rupture or injury to the major vessels or any tumor bleed, then airway secured is the first thing to do, followed by management of that bleeding part, bleeder part, in order to control the bleeding. Last but not the least, regarding what is the domains of this palliative care, as we can see, there is a palliative care role, which is the which came where we do the structure and process of the care, physical aspects of care, psychological aspects of care, social, spiritual, cultural aspects. What should we do? What should we do for the care of the imminently dying patient, and what other ethical and the legal aspects should be there? So this supportive and palliative care is a multidisciplinary approach where there is a role of head and neck surgeon, medical oncologist, radiation onco, plastic surgeon, recon surgeon, physician, and pathologist and radiologist to decide further how to manage these patients. Like pain control management is a very important part. How to decide all other factors. Last but not the least, what is the take home message? First is regarding the management part, whether to go for the curative part or the palliative part. Performance status is very important. Patient selection is the key factor. Second, if the masticator space is involved in oral cavity, it doesn't mean that the disease is inoperable. It depends whether it is a low ITF or high ITF, infranotch or supranotch. Third, if the disease is borderline resectable, consider for NACT first and then definitive treatment. It will always going to help. If the disease is unresectable, go for the concurrent CTRT or chemotherapy with or without immunotherapy. or the metronomic chemotherapy, and the last regarding the palliative or supportive care. Thank you.
So you are done with your presentation, Rizul?
Yes, sir.
So just can you summarize, like, in a few lines, like, what did you present right now? What do you question is that what do you understand by advanced